Well, thank you very much, and thank you for the invitation to come and speak to you all on some of my thoughts, I guess, and experience of the management of hypothyroidism, some of the challenges that we all face. So I think we're happy to take some questions during the talk if there's some aspects of it that people don't understand. I hope I've made it fairly clear to everyone. And then afterwards, we've got a detailed question and answer session for any particular queries that people might have. So I think, this looks a little complicated, but if we're aware that the thyroid gland, our little butterfly-shaped gland in the neck, makes two hormones, thyroxine, which is called T4, and then that itself is largely converted, both in the thyroid and peripherally, to perhaps a more active hormone called T3, liothyronine. My analogy of them is that the thyroid gland is, in essence, like the choke on our car engine. And these hormones regulate our body's metabolism. So having an underactive thyroid is like trying to start your car perhaps this morning without the choke. Everything just becomes just a bit more sluggish and difficult. Whereas having an overactive thyroid is like running your car with the choke pulled out all the time. Everything is racing away too quickly. The thyroid gland, perhaps like all the glands in the body, is regulated by the master gland, the pituitary, which is a tiny gland about the size of your fingernail or a pea, situated at the base of the brain, a few centimeters back, sits under the brain, and it sends controlling signals to each of the glands in the body. But for the thyroid, it sends one rather unimaginatively called the thyroid stimulating hormone. And that tells this chap to work. And these two work exquisitely closely and in harmony with each other to keep the level of our choke set at the right level and the amount of thyroid hormone. If your thyroid gland packs up, this chap senses it and the level of TSH will go up because it's trying to whip your thyroid to make it work harder. And conversely, if your thyroid gland on its own is making too much hormone, the pituitary gland senses it and switches off, and your TSH levels fall. Above the pituitary gland is the hypothalamus, which is the super master gland, and that controls, in essence, the pituitary. But for clinical practice, disorders of the hypothalamus are extremely rare, and it's really, we just need to know between the pituitary and the thyroid. And I guess one of the messages from this, and we'll come back to later, is that if you are interpreting, in my opinion, if you really want to interpret how the thyroid gland is working, you always have to measure both the thyroid gland hormones and the pituitary hormone, the TSH. You can't use one on its own. So most of the thyroid gland, it produces some T3, but most T3 is produced by conversion from T4 to T3. There are controversy regarding the relative effects of both, but in general, T3 is much more potent than T4. And importantly, it also has a much shorter half-life of around a day. Thyroxine, T4, is very stable. It's long, it's stable, it's a little bit like a loaded oil tanker. You can't change its course quickly, you can't change its levels quickly. If you've got to stay at this level, it lasts many days. T3 is much shorter, and that has implications if one is going to use it for treatment. Now, the thyroid stimulating hormone, the TSH, it is the test most commonly used in general practice to assess the thyroid gland. As I've said, can be suppressed if you have an overactive thyroid in thyrotoxicosis, and conversely, it is raised above the normal range in underactive thyroid or hypothyroidism. The trick, or one of the issues we've discussed, is that you can get TSH levels which are just don't make sense if you're measuring it on its own. And if you can have a normal TSH if you have an underactive thyroid, which is due to pituitary disease, and the signal's not getting from your pituitary down to your thyroid. But your TSH would appear perhaps normal, and your less experienced physicians or general practitioners will often say, well, that's all we need, your thyroid gland is normal. And that's a fundamental issue I have with just relying on TSH measurements. So we can a low TSH, which we see quite often, yeah? And I see it in around 20% approximately of patients with underactive thyroid on maintenance treatment. Yeah. If it is low, the standard thing, and you may read this on your laboratory reports, if it says low TSH, indicates over replacement with thyroxine, suggests reducing the dose. That's a very common statement that the pathology lab just prints out automatically. And yes, it can be true that if you're on too much thyroxine, your TSH level will be suppressed. However, another cause for the TSH being low is actually if you have pituitary disease and your pituitary is just not making TSH. It's rare, but it certainly happens. And if you don't look for it, like in many things in medicine, then you won't diagnose it. So you always one should be aware of it. But perhaps one of the most common issues I see in my practice, and no one can give me an explanation for it, is just the TSH level is just low. Completely normal T4 and T3 levels in patients who are maintained on the usual dose of thyroxine in hypothyroidism. They're clinically absolutely not over-replaced because the lab levels of the free T4 and the T3 are normal. Clinically, they're not over-replaced, but the TSH level seems low. I've asked all of the chemical pathologists, who run the assays as to the rationale for it. They can't explain it. But I'm definitely seeing it more and more. And that's why you cannot rely just on the TSH assay. You have to measure all of them, the TSH, the T4, and in my experience, the T3. Then you get a proper assessment of an individual's thyroid status. So the tests of thyroid function, well, we've really covered it, but you need to measure all of these. Yeah? If you're assessing thyroid function and the consideration that somebody might be overactive, yes, then you have to measure the T4 and the T3. You can have solitary elevation of T3. Now, I'm showing my age here, but some of you may remember George Bush Sr. He collapsed when he was out running. It took his physicians over a week to diagnose him with T3 toxicosis. And he had irregular heart rhythm, which caused his collapse. His T4 was normal. So even the top doctors in America managing the president missed it. So again, it's one of those things I would suggest to teach the students. If you don't look for it, you're not going to find it. And you just need to measure it all just to get a comprehensive review. So the other test we should measure is the thyroid antibodies. Yes, because these, are the most common cause of thyroid disease, whether indeed it's overactive or underactive, is autoimmune thyroid disease. Yep. And we should measure the anti-thyroid globulin and the anti-thyroid peroxidase antibody levels, because they also help me guide treatment or whether to start somebody on treatment. And, going the opposite end, but the most common cause of overactive thyroid is Graves' disease. And you need to measure the TSH receptor antibody, which is the cause of that. So you need to measure all these antibodies, certainly in the initial assessment of someone with suspected thyroid disease. They're very little use in continuing to measure them. They're not going to help you treat somebody, because then you need to give them thyroid medication appropriately, and the antibody levels are rather irrelevant. But certainly at diagnosis, I believe you need to measure all of antibodies. So the measurement of thyroid, or the assessment and treatment of thyroid disease, should be multidisciplinary. And basically, between an endocrinologist, you need to have a very good radiologist that you trust, who will usually do your ultrasound scan. And like many physicians, we get our preferred specialists that we trust their opinion, and they will give you an idea of the size of the gland, the blood flow through it, does it look active autoimmune disease, any nodules, what's the characteristics of them. And then you need to work with a good surgeon, because ultimately a lot of thyroid disease does require surgery. It is perfectly clear, it seems to have taken the surgeons an awful long time to recognize it, but perhaps the more you do of something, the better you get at it. And thyroid surgery should be done by a thyroid specialist surgeon. As a slight aside, but lots of surgeons like to do thyroid disease because it's relatively straightforward, it's quite nice for them to do, but your complication rate dramatically is lower the more you do. It isn't rocket science, it seems pretty common sense, but it's taken them a long time to get their heads around it or to accept it. So the thyroid disease, well, we can quickly skip on the left side, which is the hyperthyroid or thyrotoxicosis. The causes is Graves' disease, which we've discussed is the autoimmune one, or lots of nodules within the thyroid, which are autonomously producing too much thyroid hormone. So we call that the toxic multinodular goiter. Goiter is a medical term for any thyroid enlargement. You can have a single little benign nodule making too much thyroid hormone, and you can have inflammation of the thyroid. Factitious is the the medical term for patients who are taking too much thyroxine. Sometimes they, for whatever reason, want to become thyrotoxic and they're taking too much thyroid. On the underactive thyroid, hypothyroid, the most common is autoimmune. I've put here Hashimoto's. Hashimoto's disease is actually not all cases of underactive thyroid. It's Hashimoto's disease, first described by Mr. Hashimoto over 100 years ago, is actually autoimmune thyroid disease, hypothyroidism, within an enlarged gland, with a goiter. The most common cause, certainly in the UK, is straightforward autoimmune disease where the gland actually is small and shrunken and becomes rather withered. And that, strictly speaking, is not Hashimoto's. But it's a slight semantics for most people, including most doctors. Hashimoto's disease encompasses all autoimmune hypothyroidism. The other cause of hypothyroidism is clearly after surgery, if you've had all of your gland removed or the majority of it. Generally, you need around 20-30% of your gland to remain to make sufficient thyroid hormone. So you can certainly have one half of it removed. You can have the one half and what we call the isthmus, which is the bridge between the two lobes, removed, and the remaining half should be sufficient. And the other common cause of hypothyroidism is after radioactive iodine, that you might have had treatment for Graves' disease or for an overactive element. So hypothyroidism, which is mainly the topic of today. Well, we've discussed really all of these issues. The bottom one, the cause is iodine deficiency, is not really a case in the UK because we add iodine to the foods many, many years. So we don't have iodine deficiency. It still occurs in some underdeveloped countries. So in essence, you get the antibodies, they attack your thyroid gland, and you get inflammation of it and destruction of the thyroid gland. That, in essence, is the cause of the autoimmune nature. There's a lot of controversy, as to whether you can influence the cause of it once you have antibodies. The evidence for that is pretty, not so strong. Some people believe that, going gluten-free can reduce the prevalence of antibodies, changes in the diet. I have to say the jury is very much out. I'm not against it, but I don't think there's hard evidence for it. Your predisposition to having antibodies is, I'm afraid, just genetically predetermined. Runs in families, women 10 times more than men. And if you take a family history, usually somebody in the family has had autoimmune thyroid disease on the maternal side. Mother, grandmother, auntie, cousin, someone will have had it. Those antibodies, you have around a 3 to 5% chance a year, if you have antibodies, of becoming frankly hypothyroid. So in 10 years, you've got around a third chance that you will have underactive thyroid. Well, I think the symptoms of thyroid disease, they're slow. It's classical. And if you think of your metabolism slowing and running your car with a low choke, then you're going to get symptoms such as this. You feel more tired. Yeah? You're not burning your fuel so quickly, so the weight goes up. You get the bowels become sluggish, and you just mental confusion, just not firing on all cylinders. You get the skin becomes the dry, you get the coarsening, brittle hair loss, you get the cold intolerance, you get fluid accumulation, puffiness. The classic medical term is you get the complexion peaches and cream. Yes, you get a pale skin but slight rosiness to the cheeks. It is, the bottom one, it is a reversible cause of dementia. And in confusion, in elderly patients, it's one of the tests that every doctor should have to test for because it's so easily reversible. Dysarthria, difficulty in speaking. The voice gets hoarse, so you get a lower croaky voice, this classically, but can, in severe cases, have difficulty actually articulating. The loss of the eyebrows, many of you may be aware of, it's actually pretty unreliable. There are other causes for it, but it is a classical cause of it. It can give widespread, generalized, non-specific abdominal symptoms, constipation, general abdominal ache. And in the heart, you get slowing bradycardia, is a slow pulse rate. The heart doesn't, in severe cases, doesn't pump so well. You get effusions, which is a fluid accumulation around the heart. Again, rare, but in severe cases. So, how do we diagnose it? Well, as I've said already, I think you need to measure the T4 and the T3, and they will be low. And correspondingly, in classical cases, the TSH level will be high. It's trying to drive this failing thyroid gland to whip it harder so the TSH levels are high. In all thyroid disease, and in all endocrinology actually, your pituitary and your end organ hormone, in this case the T4, will be opposite. So T4 is low, TSH will be high. If T4 is high, TSH should be low. And then you need to measure the thyroid antibodies. And that starts to give you a comprehensive assessment of your thyroid. We usually often want an ultrasound scan as well, in addition to that, to complete the initial assessment. So we've come across this already, we've discussed, but clinicians need to be aware of the low T4 and the normal TSH, is what we would call inappropriately normal, because it shouldn't be normal. If your T4 is low, your TSH should be high. So if it's inappropriately normal, you've got to think, is this possibly pituitary disease? And then it's a whole raft of more complicated investigations because you do not want to miss a pituitary disorder, which is one of the most important ones is pituitary tumor, benign tumor of the pituitary. But this is a very classical issue for GPs will miss this if they're just relying on TSH levels. I'm not, it sounds though I'm sort of against GPs. I'm not. They do a fantastic job, but GPs are often actually limited in the tests they can order by the pathology lab. So the lab is the lab who won't let them order them. And certain GPs, in my experience, are very, very rarely allowed to measure or request T3 levels. It's just struck off by the lab. They come back with this nonsense of GPs aren't clever enough to interpret a T3 level. It's cost saving, it's historical, but it's just patent, to be frank, rubbish. It's, so GPs, they're not always at fault. There's just their hands are often tied by other, authorities. So the treatment of it, well, in essence, everybody who has diagnosed with primary hypothyroidism should start with thyroxine. Start on a lower dose, gradually titrate the dose up. You start on a very cautious lower dose in more elderly patients, because if you can imagine, it makes sense, if you've been used to being underactive for a long time, you don't suddenly want to give the body a great big jolt of a large dose of thyroxine. So you just start slowly, gradually titrate up. Yeah? You know, I've alluded already to the loaded oil tanker, but it takes 6 weeks really after you've started someone on thyroxine for the body to equilibrate to that dose before you can remeasure it and change the dose, change the course. There's no point doing it weekly. You'll get into all sorts of mess. Slow but steady adjustments, and gradually you get people back to normal. So a controversial issue is this, what we call compensated hypothyroidism. So you have a normal T4 level, usually in the low normal range, but T4, but your TSH level is slightly increased. And this is a very common occurrence. And the question of this is, you know, how many of those individuals are going to progress to frank hypothyroidism? How many of those individuals need treatment or should be treated? The current guidelines for this, for most GPs, are you wait until the TSH level is around double the upper limit of the normal range. So usually wait until it's more than 10 units. That's a straightforward sort of knee-jerk guidelines. In my opinion, completely inappropriate, far too dogmatic. So, in essence, and I don't think it's rocket science, I'm afraid, is listen to the patient. If the patient has got symptoms, then every doctor should be there with thinking, why? What's the cause of those symptoms? You know, there is something that is an issue. Yes, and the doctor's job should be to try and tease out what the cause of that is. It's not to straight away say, well, I don't actually hear you. I'm telling you, your TSH is only 6. You don't need treatment. Which is what, you know, I'm afraid, sadly, I hear time and time again. Yes? And it's just bad medicine. I mean, your first day of medical school, you say, listen to the patient, you know. And that's, people then seem to forget it as soon as they've become a DR. So, you will come to no harm, and ultimately, the only way, and the way I treat my patients, is if you think the symptoms could be compatible with low thyroid, is give somebody a trial of thyroxine, a pragmatic trial of it. Get your T4 levels into the mid-upper normal range. Get the TSH level down into the mid-lower normal. See what happens to the symptoms. The patients will say, well, actually, I feel markedly better. I want to stay on this treatment. Or conversely, you know, patients will say, well, actually, I feel no different. I don't want to stay on this. I'm not taking a pill for the sake of it. So you stop it. You've had that trial. Both of you then know, you know, and then you either continue with it or you don't. And as long as the dose of thyroxine is not too high, I see no harm with that whatsoever. It's the only sensible, pragmatic way of knowing, you know, if somebody is symptomatic due to TSH. And I've had patients with minuscule elevations of TSH levels, profoundly symptomatic, who respond tremendously to appropriate T4. Conversely, you have patients with massively elevated TSH levels, absolutely fine. No symptoms whatsoever, however much you prod them. So that's the joy of medicine. Everybody is different. So, and furthermore, I have had some patients with completely normal TSH levels, but who have high levels of antibodies, and who are also have symptoms compatible with hypothyroidism. I can't explain it, I'm afraid. You know, I try, but I can't. But they have responded to thyroxine and feel markedly better. So, you know, to my opinion, if your patient feels better and you've obeyed sort of the first law of medicine, which is first do no harm, then carry on. Continue with the thyroxine. If you've helped that patient's symptoms and you're not harming them, then it seems absolutely fine to continue with that. I can't explain why that should be the case, what the physiology is, but if it is, I'm pragmatic enough and will believe I am with having seen enough over the years to go ahead and continue with it. So the other area of controversy is hypothyroidism in pregnancy. And this is where people get very sort of worked up over it. The evidence for this is pretty slight. It's not nearly as dramatic as patients indicate. What you do want is to achieve euthyroid, which is a normal thyroid levels prior to conception, and not to have markedly elevated TSH levels. You need to, during pregnancy, you need to measure the T4 levels and TSH because the requirements for thyroxine in individuals with hypothyroidism gradually or usually increase in the first 2 trimesters. So the first 2/3 of pregnancy, your levels will go up a bit, and then stabilize. And then post-delivery, they fall back to normal. So as long as women are monitored by an endocrinologist and assessed, there's no big issues with it. So the difficult situations which sometimes cause some challenges in hypothyroidism is the fluctuating T4 and TSH levels, which don't often make sense. The levels, every time you see a patient for review, they're swinging. It is usually due to variable, for whatever reason, due to variable compliance with the medication. There is nowadays an issue with different formulations of thyroxine, and I see for different brands of it that are supposedly the same strength seem to cause changes. So I always, if this becomes an issue, try and then encourage the patient to stick to the same brand and insist from the pharmacy that you get the brand that you were on and use that one all the time. That's not easy, but or switch to different pharmacies. They should be able to obtain them. So the other very common issue that clinicians will experience is that your T4 is all normal, your TSH is normal, but you're still tired. Patients are still tired. Don't feel any different. Yeah? Well, again, you have to listen to the patient. In my experience, say, well, why should that be the case? Yes? If you've excluded thyroid disease, and we'll come on to the other big issue later of the T3 treatment, you need to consider other causes and do other routine investigations. The most common other associated autoimmune disease after thyroid disease is low levels of vitamin B12, pernicious anemia. So you have antibodies which block the absorption of B12. It's a very cheap, very simple, straightforward test, measure B12 levels. Very commonly, I'm afraid, in the UK, we are low in vitamin D. Low levels of vitamin D results in symptoms very similar to hypothyroidism. It's so simple to treat, so easy to test now, and a very common cause of significant feeling fatigue, brain fog, muscle aches, just a bit below par.
Can I ask you about B12? Mm-hmm. How long would it take for your level of B12 to be reduced? Because some of the path labs won't test within a certain length of time.
Yes.
And I was told that they won't test because there's a lot of B12 still in the liver.
Yes.
And, sorry.
Well, and what interval were you trying to test?
Well, they were talking about 88 days. I mean, it was
3 months. 3 months is probably quite soon to see a drop.
Yes. Question because it won't be captured on microphone.
Yes. So the question was, if you suspect that you have low levels of B12 and they've been normal, how soon can you retest them in case they've fallen. Yes? If your symptom, it depends again on the change in symptoms. Yes? If you were, you had symptoms then, and your B12 level was in the mid-high normal, and you've got the same symptoms 3 months later, it is unlikely that it's due to low B12. It's only because if you've had a change in your symptoms, yes? But the B12 level certainly within 3 months is going to be still the same.
It's still...
Yes.
Yeah, okay.
Yes. Maintenance doses of B12 is injections every 3 months to replace it. So, but it's an important one to assess. Rarely we need to check the cortisol level, because the other autoimmune condition that can cause fatigue is autoimmune destruction of the adrenal glands, which make our body's most important hormone, cortisol. And so you do need to check that. It's rare, but it's probably, well, it is actually, the most serious endocrine condition, potentially fatal. So that needs to be excluded. Very rare. The concept of adrenal fatigue is a bit of a misnomer. It doesn't really exist. Level of vitamin D replacement, should it be once weekly at a high strength or once a day? It doesn't matter. It is a fat-soluble vitamin, so it's, again, very, very stable once you get levels up.
So, sorry. Fat-soluble, does that mean I should perhaps take an oil capsule?
No, whatever you want. No. Vitamin D, the most common source of it, used to be cod liver oil. Yeah, if you can. It tastes disgusting. I mean, it's what your grandmother used to give you daily, cod liver oil. Yes, it's vile. It's much easier just to take a tiny high-strength capsule. Whatever is easier, once a day, once a week, whatever you get into the routine of. You don't have to taste that disgusting bitter cod liver.
So once a week, how much do you think? 10,000?
Personally, I'm in favour. The recommended dose of vitamin D is 400 to 500 units a day. Far, far too low. I reckon it's a minimum of 2,000 a day. Individuals often need much, much more, up to 5,000 a day.
14,000.
Something like that is absolutely fine. Yes. There's a wide safety range of vitamin D. If you take very high doses too long, then yes, it causes high calcium levels and adverse effects. But you need to take your standard dose, whichever you think, and then recheck it after a few weeks. And ask your GP too, or to be frank, nowadays there's such cheap private pathology labs, reputable ones online. You can get it done. But it's a really easily and treatable means of avoiding a number of symptoms.
Just an last question. Are these all routine tests?
They should be. This is nothing special. These are all routine tests that your GP or physician should have, can easily run.
So I don't think they're routine because I've had to fight for these tests.
Well,
So I don't
okay.
understand what GPs or even like a specialist has.
They should be, if you still have symptoms, certainly, but they should be checking these to start with to exclude any coexisting autoimmune disease.
None of them were tests. I had to read up on them and answer them, and then still.
Well, your anemia, renal, and liver function is a straightforward virtual test that every doctor. It's the most basic blood test. Yes. Iron levels are pretty common. Vitamin D should be routine. B12 should be routine.
It's a shame that they're not.
So.
That GPs don't know that.
Pass. Yes, on that. And then a very common situation that Lorraine alluded to that I'm seeing and by default over the years have considerable experience in is post-viral fatigue, stroke chronic fatigue. It's probably the most common reason patients come and see me. They say, I'm fatigued, it's my thyroid. You work out, no, your thyroid is absolutely fine. It's then you say, by listening to patients, you say, but hang on, I'm fatigued, I've got all these severe symptoms, and you work out it's post-viral fatigue. And it's a very, very common, we're digressing slightly, but it's such a massive issue in this country, the number of people it affects. It is a clinical diagnosis, yes, and it is an overwhelming sense of fatigue. Yeah. And I don't think, unless patients have experienced it, they know what it is. You know, we're all knackered. We're all fatigued. Day-to-day life, we're just, yes. Post-viral fatigue is fatigue you just can't even get up off the sofa. I've had it once or twice, fortunately just for a day, you know, during a viral illness. Yes. And this is, it just goes on and on. You know. There's certain severe clinical features. You know, there is a variation day to day for no reason. It's one of the first things I ask patients, is it, you know, day to day, some days are much worse, some days for no reason, patients feel slightly brighter and better. Yeah. They do too much, they pay the price. Post-exertional fatigue is the classical thing. They try and do some exercise and that wipes them out. Mm-hmm.
So would it be unusual to be first told that you have chronic fatigue and then many years later to be told, actually, no, you have a thyroid condition, and then post that to be told it's actually Hashimoto's, because it keeps changing?
Well, the two diagnoses are separate but with similar symptoms. If you've, you know, somebody who comes with fatigue, you should be assessed for your thyroid as a diagnosis at the first onset of your symptoms, because, touch wood, that's what you want, yeah? Because it's an easily treatable form of fatigue. One of the real issues with post-viral stroke chronic fatigue is that there is no quick fix for it. There's no easy treatment. I can give a diagnosis with a high degree of certainty, but the management of it is often problematical because it's slow graded rehabilitation.
So if something that you were told would have been chronic fatigue doesn't seem to show up in blood tests or even TSA?
Correct. Chronic fatigue, there is no blood test for. Yeah. That's why it's a clinical diagnosis and one of exclusion. Obviously, you can't comment on specific situations, but yes, I mean, part of the rule out for fatigue should be those, these investigations, and including your thyroid, detailed thyroid. This is a basic fatigue screen. And it's when all of these are normal and you have these classical features of it that you end up with a diagnosis of chronic fatigue. You get the unrefreshed sleep, the mental brain fog. You know, to the degree patients just can't do, you know, really hold down their job with it. It's often, I'm afraid, well, it often affects high achievers, high professionals. Yes, the accountants, the lawyers, the financiers, people burning it hard all the time, foot flat on the gas. Yes, and there's no leeway. Usually the most common original precipitant is glandular fever, Epstein-Barr virus when they were a teenager, and then that was, you asked them, was a bad glandular fever that caused them to be off school for GCSEs, A-levels for some time. They just about recovered. Then they went into a high-pressure job doing an awful lot, both professionally, socially, and then they have another virus or life event that triggers, blows the motherboard, and then they just, from then on. So it's a devastating illness, and it's something I feel a lot, quite strongly about, because I see just the overwhelming effect it has on patients, that many doctors, I'm afraid, dismiss it. You know, they still don't a classical doctor, I'm afraid, is, if they don't understand it, I'm afraid, turf it back to the patient. Well, it's you. You're depressed. Yes, is the easiest way to get someone out the consulting room. I'm afraid it's usually the patient may be depressed because in response to their illness and how devastating. It's very rarely, it can happen, but very rarely is it primary depression causing the symptoms. So, I mean, management of post-infectious fatigue, I prefer that term rather than chronic fatigue, because chronic by its nature suggests it's chronic, there's no hope. I certainly don't like the term ME, which is alluded to this, but ME has too many, in my mind, negative connotations. Post-infectious fatigue is a very specific, real entity. Just because doctors, we don't understand the full mechanisms why it happens, does not mean it's not there. We need to be honest about it and say, I can't explain to you the causes of this, why it's giving you the symptoms, but I know it's there. This is the best we currently have to help get over it. And within all of this, you have to slowly pace, slowly graded pacing. My analogy to it is it's a footballer who's completely rogered their hamstring. And for them to get back to first team football is at least a year of very slow, graded rehab. And if they do too much, their injury breaks down, in fact, even worse, and they go right back to the beginning again. And so there's no quick fix. And it's rationing all of the energy expenditures, not just physical. It's the mental, it's the psychological, it's the social, emotional, every aspect. And it's a big diagnosis for people who, I said, often have been quite high achievers, busy in their professional jobs, to come to terms with, because they look fine from the outside. The blood tests are fine. Their employers think they're probably swinging the lead a bit. Partners start thinking, come on, you could do a bit more. We'd all like a rest, if we could. So it's quite challenging managing all of that to slowly get them. But with appropriate structure and people engage with this, you have a very high success rate of getting people significantly, if not completely, improved. So it's quite rewarding professionally to help. So back to hypothyroidism. Well, this is perhaps one of the most controversial questions, is this T4, T3. There's no doubt that in my opinion, around 10%, could be a bit more, but a significant minority of individuals who with hypothyroidism, who are on adequate doses of T4, in my practice is to get your T4 levels into the high normal range, your TSH into the low normal range. But despite that, they still have symptoms compatible with ongoing hypothyroidism. And the question is, well, do they need T3? Are they converting their T4 to T3 adequately?
So if you was only diagnosed with, say, celiac disease 10 years ago, when all your life you've been complaining with issues, and then your antibodies over 1,300, and you were just discharged,
yes,
and with no medication, and left to do, live
yes,
like this, how is that possible? How is that doable? Why are we allowed to just be discharged with no treatment, with antibodies, with celiac, and not actually given Hashimoto's as an actual diagnosis, that you have to go and source it through a very expensive GP,
yes,
and get pig thyroid,
yes,
and you're managing it on your own? And how is this even, sorry, I'm just getting very emotional, how is this even possible that this is allowed to happen?
Well, you need to, in my opinion, as I've said, measure all of these things to get a comprehensive assessment of it, and have at least a trial of it, and to see if that helps matters. I can't comment on individual practices, but I've given, I hope, an idea of what I believe is the appropriate way of investigating and treating individuals with symptoms.
Let me just say something, actually, because I can see that you're feeling emotional, and there's probably a lot of people in the room can relate. Yeah, come back. We obviously do these meetings fairly regularly, and the majority of the time are probably people who, as I was, hard to treat, might have been fobbed off by the doctors or felt that they have been. And I'm very aware that there are lots of people who've ended up having to resort to even self-treating, and it's not a good state of affairs. And I just wanted to step in because I could feel the emotion from yourself and probably across the room to say, this is partly why we exist. This is what the Thyroid Trust is for. This is what this video is for, is to raise awareness of the importance and the significance of thyroid disease and the extent of how it can be debilitating on people's lives. not just with patients who are already interested because we've got it and we want to be self-educated, but also to really sort of help educate both professionals, health professionals, and also health policy makers. And you know, we've had some successes even in the really short time that we've existed, and we hope to do a lot more. And it's about making thyroid disease more interesting for clinicians, which is dreadful that we should have to do that as patients. But I think, you know, we've really got a chance of making a difference. You know, there's been lots and lots of press recently as a result of work that we've done with our partners. You know, there's been a debate in the House of Lords, there's been the big report that we did at the end of last year. We're having some real success working with NHS England on changing the guidelines, and I'm going to say a bit more about that later. But just wanted to say, you know, Paul is an amazing doctor in and of himself, but he obviously can't be responsible for what the medical profession as a whole do, but he's working with us and supporting us, as is Dr. Toft, who spoke at our last meeting, so hopefully there's some hope.
Mm-hmm.
You don't need this, do you?
No, I think I'm good.
Thanks for asking the question.
So I think, you know, the T3 issue is very, as we all know here, very controversial. Yes. One of the issues with it is that the studies that have been done on, you know, resolving symptoms of hypothyroidism with T3 have shown no benefit. And so therefore, you know, when you've got that, if perhaps you start with a slightly negative mind frame, then that's all the proof you need, well, T3 doesn't work. Yeah? I think you still, though, you know, got the question, firstly, the first point, patients still have symptoms compatible with hypothyroidism. And then if you give patients T3, many of them feel markedly better. You know? And that's one of the most, you know, gratifying things. If you patients have had symptoms for 10, 15, 20 years, you know, and you give them T3, and you get stories like, oh, I've got my life back. For the first time I know what it's like to be normal. You know, I feel so dramatically better. Well, we've had this debate at the Society of Endocrinology, I think 2 years ago. Some of my colleagues say, well, it's a placebo effect. I have to say, I mean, my answer to that is, well, go and start seeing a few more patients, yes, and see that. But even if it is, okay, I can accept that, okay, so what? Patients feeling better. As a pragmatist, I would say, well, I don't care how you feel better, as long as I repeat, are not doing any harm. So if you feel better, do you want to say it's a placebo effect? I say it's a real effect. The patient is better, they're happier, then I would call that a result all round.
Could I ask you about T3, which isn't normally prescribed by GPs? Are there some background reasons? Is it difficult to obtain? Is it very expensive? What is the attitude nice to it? Given that it does have the advantageous effects that you talked about, could you give us some of the small p political reasons why GPs are not onto this?
Well, this is, as Lorraine said, one of the great debates, issues that they're doing such fantastic work in combating. And so I'm happy to try and assist where I can. Lorraine may have more knowledge, but in essence, it's price. It's money. Yeah, like most things nowadays, if it comes to money.
That's what I expected. Thank you.
With T3, say somebody took T3 and they didn't need it, would they have negative symptoms?
They can do, yes. So I'll come on to this, because it's not straightforward, as T3 is not a panacea for everything. Yes, I think we need to be clear. 90% of individuals with hypothyroidism are managed perfectly well on T4. If you can get away with T4, that's what you want. It's safe, it's stable, it's cheap, it's simple to take. And if that resolves your symptoms, then great, fantastic. And I certainly, that's the treatment for 90% of individuals. So I'm certainly not saying that T3 is the first line treatment. What I am saying is that clinicians should be aware that there is a significant subgroup of individuals with hypothyroidism who have normal T4 levels on adequate doses of thyroxine, who still say, I'm not right. My symptoms are still here. I may be a little bit better, but I'm not where I was, where I should be. And that's the subgroup that clinicians should be saying, well, why is that the case? And for those individuals, if you measure their T3 levels, you often find that they are at the low normal range. Yeah? If you measure the inactive form of T3, a substance called reverse T3, which you can now do, they're pretty reliable assays for it, you find that the reverse T3 levels are in the high normal range or higher than normal. That's a completely inactive form of T3, so it's not doing anything. If you convert normally T4 to T3, then I would expect, it seems logical, that if your T4 level is in the high normal range where we've agreed we want it, then your active free T3 level should be in the high normal range. You should be having an efficient. We now know some of the reasons for this, of this conversion, is without getting too technical, but deiodinase enzymes, which convert T4 to T3, and you can have genetic variations in those enzymes which make them less efficient in converting. We now know what those genetic, not abnormalities, but what we call polymorphisms are. To some extent that's okay, but it doesn't affect the end result. Yeah? Your T4 level is high normal, your free T3 level is low normal, your reverse T3 is high. And I've got symptoms. You put all that together, to my mind, it then seems pretty straightforward that it's worth, in those individuals, a trial of T3, additional T3.
Sorry, I'd like to challenge you on where you said if FT4 is high, FT3 should be high. I'd say that's not so. In healthy people, the free T3 is maintained around mid-interval because there are two types of deiodonases and they kick in to sustain normal T3 levels. You did mention earlier that when TSH is a bit lower than it should be for a normal FT3, FT4. FT3 is often low, and those people are problematic. I'm actually doing some research on that, but I don't want to get into too much depth because it takes long. But we have to look at where the T3 is coming from. And in those patients that have a high TSH and a low FT4 and feel well, they normally have a normal T3. And in that case, the type of deiodanase is called type 2. And a lot of that T3 comes from the brain, type 2, which comes from type 2 deiodanase. And so those people are well. If they have a lowish TSH with a lowish FT3 and normal FT4, they don't feel well, and then not much of that T3 is coming from the brain. So 2 points. One, that I disagree that if FT4 is high, FT3 should be high. It's normally middling.
Okay.
And the second thing, and this goes into another dimension that we can't go into today, is that we have to look at where the T3 is coming from.
Okay.
I think that's really
Okay.
essential.
I mean, I can accept some of that. I think, though, ultimately, you have to listen to the patient and the symptoms. And it's if the patient has symptoms and your T3 is middle or low normal, yeah, they've got symptoms compatible with it, and they've been treated with adequate doses of T4, my point is it is worth a trial of T3 to see if it makes them better. If it doesn't, you're not going to carry on with it. Certainly not because of all the issues of getting hold of it. But if it does make them better, and you're not over-replacing the patient, then continue with it.
Absolutely. I could go one step further, that perhaps they need slightly higher levels of T3 than normal because of what I've just mentioned.
Okay, that is an important point, is the dose of T3, because too high T3, and this is where the controversy comes from the anti-T3 movement thrives on, is that too high a dose of T3 undoubtedly does have significant risk effects. And so you have the risk of, we've alluded to George Bush Sr., Irregular heart rhythms, atrial fibrillation is the most significant one, because that in itself is a significant risk of stroke. So no doctor wants to be prescribing a medicine that causes a stroke. That's just obvious, but that's what doctors are very twitchy about. To a lesser extent, high doses of T3 also exacerbate osteoporosis. And you're talking of a population that is already at risk of osteoporosis through their age, often.
Yeah, I'd agree.
So I think, but notwithstanding that, low dose of T3, and again titrating the dose up, you're not going to come to any harm. But it does allude to one of the issues, which is the T3 formulations. Because a lot of these, and a lot of the combined ones, a lot of the common ones have too much T3 in it for the T4 amount. And so you get too big a dose of T3. And that's why really I don't like using any of these, because the ratio of T3 is too high. So you are at risk of making those patients T3 toxic, over replaced. There are also, various we've discussed, but there are various supply issues with them, pricing issues. And in my mind, and the way I much, much prefer patients, we've discussed some of these, is to get the dose of T4 right into the high normal range, and then separately add in pure T3. Initially at a dose of 2.5 to 5 microgram, once or twice a daily.
Going back to antibodies again, why is it that if people have high levels of antibodies, it's more or less ignored? Because clearly if you've got high levels of antibodies, something is happening in the body.
No, not necessarily. No, so you can have high levels of antibodies which don't do anything.
But if it's causing problems in the throat, what would that be deemed as? Just inflammation?
Well, they wouldn't be, the symptoms of local symptoms would be if it was causing inflammation of the thyroid gland. You could determine that from the ultrasound scan, which is why, going back, but I like to get an ultrasound scan to it will show you the size of it and if there's any active inflammation. But often antibodies per se don't cause symptoms, but if someone has got symptoms, you need to take that into account, in my opinion, as to whether to initiate treatment. Yes. Yeah. So really this is almost, I think my end point is, proper T4 and T3 treatment is T4, low dose T3. One of the advantages and subsequent disadvantages of T3 we've alluded to is its short half-life. So if it's going to give a beneficial effect, you'll notice that effect within a couple of days. Whereas with T4, it takes weeks to see an effect, or at least a week, 1 to 2, 3 weeks. So you then need to measure the T3 dose, 4 to 5 hours after T3 level after the first dose, when you should in the blood have the peak level of it, and you can then see if it's too much. Generally, patients need usually 2.5 to 5 microgram twice a day, morning with a T4, another dose at lunchtime. If you have it too late in the day, if you're not careful, it can be like having a double espresso before you go to bed. Keeps you awake. They work the same way, they mediate adrenaline release. So you have difficulty sleeping. Some patients get away with just once a day. And some patients manage it, in the evening, like some people can have a double espresso after, dinner. It doesn't affect them. For me, I'm wiped out after about lunchtime, but.
You might want to just mention the leaflet, actually. You might want to mention the leaflet I showed you that people can get.
This?
This book is that.
Yes.
They can take and give to their doctors.
Yes, this is a very good summary of certainly individuals who are maintained or currently on T3 when they say to stop it. The Lord O'Shaughnessy has said, we're informed by NHS England that the Joint Clinical Working Group has agreed that NHS clinical commissioners will reiterate that the intention of the advice last year was to end the routine prescription of liothyronine only where it was clinically appropriate to do so. So I think that's actually a major step forward in this, only where it's clinically appropriate. And I don't think any of us would have, be against that. If it's clinically appropriate, i.e. you don't need it, and symptoms-wise you don't need it, then yes, I'm a great believer, reduce number of meds to the absolute minimum. But if it's not clinically appropriate, then we should be very robust in fighting the unilateral saying, no, we're stopping the treatment of it. So I think on that note, thank you very much.